Hi everyone! Happy to see you all in our symposium. And I am delighted to present a dear colleague and a big researcher called Dr. Ricardo Muñoz. I have to tell you that it's even more exciting because he is one of the pioneers of online interventions in the world. But he has a Latin American background. He immigrated from Peru to the Mission District, the Latino barrio, in San Francisco in 1961 at the age of 10. So it's even more exciting to have him here today. He did his undergraduate work at Stanford and obtained his PhD at the University of Oregon. He was named Distinguished Professor of Clinical Psychology at Palo Alto University in 2012, where he is the founding director of E4 Health, the Institute for International Internet Interventions for Health. He is Professor of Psychology, Emeritus at the School of Medicine of the University of California in San Francisco, at the San Francisco General Hospital. He is also Adjunct Clinical Professor at Stanford University Department of Psychiatry and Behavioral Science, and a member of the affiliate faculty in the Department of Psychology in the same university. Dr. Muñoz has served on the 3 U.S. Institute of Medicine National Academy of Medicine Conscience Committees of Prevention of Mental Disorders. He was elected Fellow of the American Psychological Association in 1989, Fellow of the Association for Psychological Science in 1994, and in February 2017, he was inducted as Fellow of American Association for the Advances of Science for Distinguished Contributions Toward the Prevention of Major Depression and the Development of Internet Interventions to Improve Mental Health Worldwide. Today, Dr. Muñoz presents us with the keynote, Evidence-Based Online Interventions to Reduce Health Disparities. Thank you so much, Dr. Ricardo Muñoz. Welcome to ALAPCCO's International Symposium.
Thank you very much, Carmen. I'm very happy, proud, and honored to have been invited to participate in this second International Symposium of the Latin American Federation of Cognitive and Behavioral Psychotherapies. And this one is focused on online CBT interventions, which is my area of interest. I would like to begin by mentioning that in 2017, the Association for Behavioral and Cognitive Therapies, the board of directors, called together the inaugural think tank to focus on digital CBT technologies to provide care to difficult to reach and underserved populations. And in June of 2018, members of the think tank published an article called Digital Apothecaries, a vision for making healthcare interventions accessible worldwide, which was published in the journal mHealth. And what I'll be talking about is many of the ideas in this article and give you some of the background of where the ideas came from and what I see as the potential for these ideas. So here are the 5 ideas I'll be focusing on. And the point of my talk is to help you think about how to actualize the full potential of online CBT. So here are the 5 ideas. First, digital apothecaries. Second, massive open online interventions. Third, consumable versus non-consumable interventions. Fourth, the limitations of what is called skeuomorphic thinking, and I'll explain what that is. And then how online CBT can contribute to making healthcare a universal human right. So let's begin with digital apothecaries. Digital apothecaries are online repositories of evidence-based digital interventions for mental, emotional, and behavioral conditions. They can be focused on prevention or treatment of these conditions. And they can provide 4 types of interventions. The first one would be online training, so we can prepare more face-to-face therapists who can provide CBT interventions. We need many more therapists in the world, and that's one of the things that a digital apothecary could do, online training. The second thing is to provide digital adjuncts to improve face-to-face therapy. For example, ways of monitoring mood, behavior, and so on that the therapist could use to follow progression and outcome of therapy. The third and fourth interventions are self-help interventions. The third one would be guided self-help online interventions, in which would be helpers, not therapists, but helpers who would help people to adhere to the online interventions. Because one of the problems with online interventions, with digital interventions, is that people drop out, they stop using them. And the fourth one is fully automated self-help interventions that require no human assistance. And because they require no human assistance, they are non-consumable, and they can help many more people than interventions that require a human being administering the intervention. So this is the idea of a taxonomy of interventions that digital apothecaries could contribute. Type 1, again, is training more people to do face-to-face therapy. Type 2 would be providing adjuncts to therapists, digital adjuncts that they could use to make their therapy more effective. And type 3 and 4 are self-help interventions. There's no therapeutic contract. There's no therapist and patient or therapist and client. These would be given to people anywhere. And type 3 would provide assistance, human guidance, to help people adhere to the intervention. And type 4 would be fully automated, no human guidance required. And because of that, type 4 interventions are non-consumable. Type 1, 2, and 3 are consumable. And again, I'll talk more about the difference between these two in a second. So what is it that they would host? What is it that digital apothecaries would host? They would host massive open online interventions. So what are these? Well, they're similar to massive open online courses or MOOCs, which are available online. They're called open because they are free to anyone, and they can be done for the entire world. Now, the way I began thinking about these massive open online interventions, which are different from courses, the courses provide information. Massive open online interventions provide actual psychological interventions that are intended to prevent or treat mental disorders. So in 1997, our research team published an article reporting a randomized controlled trial, which we conducted entirely via surface mail, printed material sent through the mail in Spanish to help people to quit smoking. And the question I had after we published this was, why not do the same using this newly created World Wide Web, which came online in the early 1990s? So I decided to try to do a set of studies to show proof of concept that massive open online interventions could be realistic, that they could actually help people. So this is the study that began all of this. It was called Tomando Control de su Vida, which means taking control of your life. And what we did is a randomized controlled trial on the smoking cessation conducted in Spanish using printed material which we sent through the mail. The PI was Eliseo Perez Table, a physician, a colleague of mine, and it was supported by a grant from the National Cancer Institute. The study consisted of the following. There were two conditions. One was sending a smoking cessation guide, La Guía para Dejar de Fumar, which Eliseo had developed before the study. And then the second condition was a mood management condition, a behavioral activation condition intended to help people control their mood, hoping that by doing so, we would help more people to quit smoking. And what we found is, in fact, that worked. by adding the mood management condition, we were able to double the abstinence rate from 10% to more than 20%. This was amazing to me that we could do this through the mail. No smoking cessation group, no therapist, just through the mail. And then I thought, well, if we can do this through the mail, we could do this through this new thing called the World Wide Web, right? So now, the World Wide Web, as I said, became accessible in the early 1990s. There wasn't the World Wide Web when I got my PhD in 1977. It wasn't there. But it had just come online. And again, I was asking, could we do the internet, use the internet to help people? So we got our first grant from the California Tobacco-Related Disease Research Program. And the goal of this grant was to help as many Spanish and English-speaking people as possible stop smoking. That was our intent. Now, we were doing this at the University of California, San Francisco, at one of our teaching hospitals, San Francisco General Hospital. And so we were interested in working with the Spanish-speaking community of San Francisco, maybe the Bay Area, the San Francisco Bay Area. Right? But as you'll see, we went much farther than that. So the first thing we did is we looked at what were the reasonable rates of helping people to quit smoking. And two of the most used methods to help people quit smoking is the nicotine patch and smoking cessation groups. So we looked at the literature and we found that the nicotine patch yielded about 14 to 22% quit rates at 6 months, compared to placebo patches, which only yielded 4 to 8% quit rates. So the nicotine patch was much better than placebo. But as you can see, it wasn't anywhere near 100%, right? 14 to 22%. Smoking cessation groups were slightly better, 24 to 27%. So our question was, could we match the patch? Could we do something comparable? So we created this website. It was available in Spanish and English, again, at the University of California, San Francisco, where I was a professor, and at San Francisco General Hospital, which is where I practiced. That was a teaching hospital of the university. And what we found is, as we started doing these studies, that we yielded as high as 26% quit rates in Spanish speakers at 6 months. And at 12 months, 20 and 21% quit rates. And this is using what's called the missing equals smoking convention, which means that if we did not get data, follow-up data on a participant, we assumed they were smoking. Right? So missing data, we interpret it as they're still smoking. So this is a conservative estimate, okay? But we concluded that we were able to match the patch. We were able to match the nicotine patch with these figures. But what was really amazing to me was the reach. We went far beyond San Francisco. We were far, far, far beyond San Francisco. Each red dot in this map shows a zip code, a postal code that had at least one visitor to our website. So from San Francisco General Hospital, this small team of psychologists and physicians were able to reach Spanish and English-speaking people throughout the United States. That was amazing to me, but even more amazing to me is we began reaching people all over the world. The darker the country, the more people that were coming to our website. And remember, this is only in Spanish and English. Imagine what we could have done if we were doing this in Portuguese and Chinese and Arabic. Imagine what could be done. So this is the potential. This is what made me feel we need to harness this power of technology and psychology, put them together so we can reach as many people as possible. So because of this, I wrote this paper in 2010 in the Journal of Medical Internet Research that I titled Using Evidence-Based Internet Interventions to Reduce Health Disparities Worldwide. So was there any evidence that I could reduce disparities, right? So I looked at our data from our smoking cessation studies, and this is some of what convinced me that we could reduce disparities. First, we found disparities in access to smoking cessation aids by language. You can see here on the left, English speakers the green, 35% of English speakers had used the nicotine patch before coming to our website, but only about 10% of the Spanish speakers. Right? Big differences there. And I'll just skip here to the right side. These are people who said they had used nothing. Spanish speakers, almost 60% had used nothing before coming to our website. English speakers, 30% had used nothing. You can see that Spanish speakers, there were disparities between Spanish speakers and English speakers in terms of their ability to use other aids before coming to our website. Right? But in terms of efficacy, you can see here at 12 months, the quit rates are 20 and 21%, almost exactly the same for English and Spanish speakers. So we could reduce disparities. When people came to our site, the effect of our intervention was very similar for Spanish and English-speaking people. So I took this as evidence that we can reduce disparities worldwide. So in 2016, we published this article in Clinical Psychological Science, which we titled Massive Open Online Interventions, a Novel Model for Delivering Behavioral Health Services Worldwide, in which we presented the idea that like massive open online courses, like MOOCs, we could develop these massive open online interventions, we call MOOIs, M-O-O-I, MOOIs. And I want to focus on a couple of issues with MOOIs or MOOCs. MOOCs do have massive reach, but they also have massive attrition. And this raises the question as to whether we should be focusing on absolute numbers reached versus the percentage of people who complete courses or interventions. So here's one example from the Massachusetts Institute of Technology that put together a MOOC called Circuits and Electronics. 155,000 people registered for this course from all over the world, but only 7,157 passed the course, which is 4.6% of those registered, right? So I think you would find this disappointing, wouldn't you? I mean, only 4%, 5% of people finished. But one of the professors at MIT pointed out that if you look at the number in absolute terms, it's as many students as might take the course in 40 years at MIT. We need to pay attention to the total number, not just to the percentage that complete. And the same thing is true for psychological interventions. You know, if you can reach 155,000 people with a website, and you can help 7,000 people, you know, to stop being depressed, that's worth it, even if they're only 4% or 5% of those who came to the site in the first place. Another major issue is cost. And here I want to delve into this idea of consumable versus non-consumable interventions. In our latest smoking cessation study, we had 18,000 people come to our website, and 19%, or 3,479 smokers, gave us data showing that they had quit. Now, to help that many smokers quit, it would have taken $3,652,950 worth of nicotine patches. Now, we were able to do this in 2.5 years for about $200,000 by keeping the research website open after our research grant ended, which is then shut it down. You know, when you're doing a randomized controlled trial with live therapy, when the grant ends, you can't continue giving live therapy, right? You don't have the money to pay the therapist. But with a website, you just don't turn it off. You just leave the website going and you can keep on helping people. That's amazing, isn't it? I mean, that is amazing. So you may ask, well, how did we get 3.5 million? Let's do the numbers. Nicotine patches cost $3 to $4 each in the United States. So in 7 days, in a week, it would be $21. And in 10 weeks, which is what people usually use, some people use it much longer, but let's say 10 weeks, $210 per smoker. Now, patches yield quit rates of 14 to 22%. So let's use 20% to make it an easy estimate here, which means that 1 out of 5 smokers who use the patch quit. So to get 3,479 smokers to quit, we would have to give the patches to 5 times that many smokers, or a total of 17,000 395 smokers. You multiply that by $210 per smoker, and you get 3,652,950. Consumable interventions are very expensive. Consumable interventions are interventions that are used up when you administer them. What do you do with a nicotine patch at the end of the day? You take it off your arm and you throw it in a garbage can. It's used up. It's consumed. The same thing is true for cognitive behavioral therapy. When I do an individual session or a group session for depression, at the end of the hour, that hour of my time is gone forever. No other patient will ever benefit from that 1 hour of my professional time. It's consumable. But a website, like the smoking cessation website, is not consumable. Thousands of people all over the world can use it. And it doesn't go down in therapeutic power. It retains the same power it had when you did the randomized control trial. The marginal cost of non-consumable interventions eventually approximates, although it never reaches zero. So let me give you an example. Let's say that a website costs $1 million to create and to do the randomized control trial showing that it's evidence-based. Let's say that this website that cost $1 million is provided to 1,000 people. So each person costs $1,000, right? Because 1,000 people times $1,000 is $1 million. So if 1,000 people use the site, each one costs $1,000 to administer. But if 1 million people use the site, then it costs $1, right, per user. 1 million people use $1 million site, $1 per user. And if 10 million people use it, 10 cents, 10 cents. That's what I mean about it approaches zero. It gets closer. It never gets to zero because you still have to pay for the electricity and to keep the website open and somebody to take care of the website. But it comes very close. You cannot do this with face-to-face therapy. Even if you give therapy away. At San Francisco General, I founded a depression clinic in 1985. And for 10 years, we did not charge patients anything for getting individual and group cognitive behavioral therapy in Spanish and in English. So it's not the money, it's the time. We couldn't help as many people as needed it. We could only help as many people as we had therapists to do therapy, right? So again, the marginal cost is the cost that it takes one to give the intervention to one more person. And that's where massive open online interventions have a great advantage. But the other advantage is that we could go beyond treatment. I mean, right now we're focused, CBT therapists do treatment, right? When people have problems, they come and we provide treatment. We don't have enough therapists to do treatment for everybody who needs it. How can we do prevention? Well, cognitive behavioral interventions teach people how to use our thoughts and behaviors to treat clinical conditions such as depression. Why wait until people are clinically depressed to teach them these skills? Why not use cognitive behavioral methods to prevent psychological problems? So let me tell you about my line of work, how I got interested in prevention and why I think prevention is effective and we should begin doing prevention. We should use cognitive behavioral methods to prevent mental problems. So what is the goal of prevention? Well, the goal is to help people not cross over this threshold into serious depression, which is when you require treatment to bring people back to normal mood. We should be doing preventive interventions before they cross threshold to prevent a major depressive episode, for example, and bring people back to normal functioning. So where did I get these ideas? First, the theoretical background. It came from social learning, social cognitive theory, the ideas of self-efficacy, personal agency, reciprocal determinism, how our thoughts affect our mood and our mood affects our thoughts. And I got these from Albert Bandura. He was my senior thesis advisor at Stanford University from 1971 to 1972. And from him, I learned these theories, including concepts of self-efficacy, personal agency, and I did my first randomized controlled trial under his supervision. In terms of practice, I use cognitive behavioral approaches to the treatment and prevention of depression, and I learned these from Peter Lewinson. Peter Lewinson was one of the pioneers in the area of behavioral activation, and he was my supervisor for my dissertation, which was part of a larger study that Marianne Youngren and Tony Zeiss and I did our dissertations as part of that big study. It was a randomized controlled trial comparing purely behavioral interventions to purely cognitive interventions to interpersonal interventions. And what we found is that all three of these did better than a control, wait list control condition, and they did about the same as each other. So we put all of these into a book called Control Your Depression, which is a paperback that's still available. And when the book was about to be published, we were contacted by one of the television networks in the US, the NBC network, and a physician named Arthur Lean, who had a health segment in the news hour, asked us if they could record us, videotape us, teaching these ideas, and then they would follow the people. These were adults in San Francisco. They would follow them into their homes, into their places of work, and where they were having fun at the park, etc., to show how they were using these cognitive behavioral mood management methods. And then they edited all these down into 10 4-minute segments, which were shown at noon, 6, and 11 p.m. in the news hour in the NBC affiliates throughout the United States. It was an amazing experience. And one of the things that happened is I wanted to see whether there was an effect, right? I mean, would this show any effectiveness? So when these were shown in San Francisco, I put together a team of students from UC Berkeley, and we did phone calls the week before and the week after the 2-week segment. And we did the Center for the Epidemiological Studies Depression Scale, which is a depression measure, before and after this 2-week period. And here's what we found. For people who had low symptom levels, it didn't matter whether they watched the segments or not. So the blue people watched the TV segments, the red did not. Okay, so you can see there's no difference. There's a regression to the mean. You can see regression to the mean here, but there's no difference for people who had low symptoms. But for people who began with high symptom levels, the ones who watched the segments actually dropped significantly more than the ones who did not watch the segments. This was my first evidence that you could use cognitive behavioral methods on a mass scale, in this case through television, and you could actually document that depressive symptoms could be reduced. So let me go back now to September 1972. I was 22 years old and I had just began my doctorate work at the University of Oregon. I attended a talk on what the psychologist who gave the talk, a man named Richard Ingram, called primary prevention. I had never heard of this before. But in brief, he chided those of us around the room, saying, you know, we psychologists, psychiatrists, social workers, we sit in our offices and we wait until people suffer enough to have to come to see us. We should be going out into the community, teaching people the things we've learned as mental health providers so that they don't have to suffer as much, you know, so they have to come to see us. And I found this idea so compelling that from that moment on, I decided I was going to devote a lot of my time to prevention. So when I came to University of California, San Francisco, at San Francisco General Hospital, I conducted the first randomized controlled trial to test whether the onset of a major depressive episode could be prevented. With primary care patients at the hospital, we did it in Spanish, English, and Chinese. Later, I did another study called the Mothers and Babies course study to prevent postpartum depression in Spanish and English. And both of these were funded by NIMH. One of the people who really supported me in this area was Jim Kelly, who was one of my mentors. He unfortunately just passed away a few months ago, but he invited me to write my first publication, which was titled The Prevention of Mental Disorders. So from the moment I began publishing, I was focusing on prevention, again, thanks to Jim Kelly. But the state of the science, even as late as 1984, was such that the National Institute of Mental Health could publish a pamphlet in which they said, in general, the onset of a clinical depression cannot be prevented. I was so irritated by this. I mean, there was no evidence that you could prevent or not prevent. We didn't know. How could they say this, right? So from that moment on, I started to really work on publishing as much as I could to try to figure out how we could do the research to change the state of the science and say that clinical depression can be prevented. I wrote a number of articles, but a couple of books. This one in 1987 called Depression Prevention Research Directions. This one in 1993 called The Prevention of Depression, Research and Practice, in which, among other things, Yuan Ying and I reported on the first randomized controlled trial that we did at San Francisco General Hospital to test whether major depressive episodes could be prevented. And because of all the work I was doing on prevention, I was invited by the Institute of Medicine to participate in a consensus committee that in 1994 did the first report on the state of the science of prevention in mental health, titled Reducing Risk for Mental Disorders, Frontiers for Preventive Intervention Research. And by the way, you can download this at no charge from the National Academy Press. If you go to www.nap.edu and enter 2139, 2139 is a number for this report, you can download the report. It's a very long report, I think about 600 pages, something like that. But it has a lot of information about prevention. And what we did in this first report is to identify, to define 3 levels of mental health intervention: prevention, treatment, and maintenance. And we define prevention as any intervention that occurs before the onset of a clinical episode. Treatment, interventions that occur after onset and while the person is still in the middle of the episode. And maintenance, anything that occurs after the person has recovered to prevent relapse and recurrence. In 1997, Mimi Lei came to do her internship and postdoctoral work with me at the University of California, San Francisco, and she and I and many other colleagues developed the Mothers and Babies course and ran a pilot randomized controlled trial in which we assigned at random women who were pregnant and using the prenatal clinics at San Francisco General to either usual care, the control condition, or the Mothers and Babies course, which was a cognitive behavioral mood management course. And we found that 25% of the women in the usual care condition developed major depression within a year, compared to 14%. So this was the first study showing that there was some evidence. There have been many more since then. I'll go into that a little later. But these are some of the women and their babies who took part in that initial study. And of course, this is the reason we do this, right? It's not the articles, it's not the statistics, it's the people, in this case, the babies. They're probably in their 20s now. Okay, so we have the manual for the Mothers and Babies course available online. Any of you can download it. We have it in English, Spanish. Somebody in Greece translated it to Greek. We would love for somebody in Brazil to translate it to Portuguese and use it there. There are many women who are pregnant in Brazil. And many women who, of course, are at risk for depression. And you can download this from our website, I4Health, the number 4 health.paloaltou.edu. In 2009, the Institute of Medicine published a second report called Preventing Mental, Emotional, and Behavioral Disorders Among Young People, in which we revised the mental health intervention spectrum. We started focusing on promotion. And again, this one is available at no charge from the same place. This is number 12480. And again, you're welcome to download this at no charge. We added a 4th level of mental health interventions: prevention, treatment, and maintenance as before, and then now promotion of positive mental health, fostering healthy development, not just preventing disorders, but promoting healthy development. Because of all that I had learned there and all the work that I had been doing, I could publish this article in 2012 with my colleagues Bill Beardsley and Jen Lakin, titled Major Depression Can Be Prevented, right? So the state of the science had changed from 1984 to 2012. And because of the work that my team and that of many other teams around the world have done, that now we could really say that this can be done. But you know, it's not happening. People are not using preventive interventions yet. And that's one of the things we could do with online interventions. In 2019, in February, the US Preventive Services Task Force published its recommendations in the journal JAMA, the Journal of the American Medical Association, in which they recommended that clinicians provide or refer pregnant and postpartum persons who are at increased risk of perinatal depression to counseling interventions. And I was very happy to see that the mothers and baby scores is one of the ones that they actually recommended. It's a CBT intervention. There's also an IPT, interpersonal psychotherapy intervention, that's also effective. But ours is a CBT intervention, and it showed a pooled risk ratio of 0.47, which means that there's a 53% reduction in incidence of mothers and babies. Right? That is, you can reduce the number of new cases by 53%. This is a number of other studies, have been used to come up with this. And the IPT also does very well, a 50% reduction. So we now have ways of preventing depression. We should be doing that. In 2019, the Institute of Medicine had changed its name now to the National Academy of Medicine. I was part of this consensus committee. We published this report called Fostering Healthy Mental, Emotional, and Behavioral Development in Children and Youth. And one of the things we did is expand the idea of promotion and talk about how we needed to implement the knowledge that we now have. Again, this is available at no charge from the same site, number 25201. Again, it's a plethora of data on prevention. So we enlarged the idea of promotion, and we said we need to go beyond individual interventions. Individual or group interventions are not enough. If we really want to reduce prevalence in the community, we need to do family interventions, we need to do community interventions and social interventions. For example, focusing on reducing poverty, which also brings up depression. So the idea here would be to build up many digital apothecaries, filling in a grid of health problems by languages, systematically developing evidence-based digital CBT interventions to contribute to making healthcare a universal human right. Imagine columns which represent health problems. Smoking is the #1 cause of preventable death in the world. Depression, the #1 cause of disability in the world. Pain, alcohol, obesity. It doesn't have to be just mental disorders, right? It could be health problems too that are amenable to cognitive behavioral interventions. And the rows would be English, languages, English, Spanish, Portuguese, Quechua, Aymara. Imagine all the people we could help. This is a never-ending project, obviously, right? You'll never finish it, but let's begin, let's get started. But would online self-help interventions provide inferior care? Right? I mean, the question I have from my colleagues is often, but Ricardo, if you do this online stuff, it's not going to be as good as if we do live therapy. You have to be there in the room with the patient to really make a difference. Well, let's see, okay? Randomized controlled trials actually show that self-help interventions are effective in terms of treatment. This is a meta-analysis published by Pim Kuipers, among others, in JAMA Psychiatry, in which they looked at the efficacy of self-guided, these are fully automated, internet-based cognitive behavioral therapy. Now, this would be what I call type 4, right? Totally automated, non-consumable, in the treatment of depressive symptoms. And what they find is, and I'll just go here, self-guided internet CBT is effective in treating depressive symptoms. I mean, you can look at the article to get all the data, but the conclusion is clear. Self-guided, fully automated, internet-based cognitive behavioral therapy is effective. Now, randomized controlled trials have also shown that self-help interventions are effective in terms of prevention. Here's an article, again in JAMA, Journal of the American Medical Association, published in 2016. This was a study done in Germany, in which they looked at people who were sub-threshold. They had some symptoms, but they did not have a major depressive episode yet. And they did a guided intervention. And they found that the people in the control condition, 41% of them developed a major depressive episode within a year, compared to 27% in the intervention condition. We can prevent depression using online CBT. And reports of, but the problem with these two is that they are randomized controlled trials, which are very closely monitored, right? Will it work if you start doing it routinely out in the community? So I looked for data on this. And of course, because they're not research studies, it's hard to find these data. But I did find something. Reports of effectiveness in routine treatment that's outside of tightly controlled RCTs shows that online interventions are comparable to face-to-face treatment. This is from the UK. As you know, they have the National Health Service. This is a study. It wasn't a research study. It was just a report of data from routine treatment. 1.25 million people who had been referred for treatment, for psychological treatment. 400,000 plus people actually completed treatment. And so they looked at how many of those people had recovered using psychological interventions. And here are the data. And what the people who did the report were very surprised that the best recovery rate was computerized cognitive behavioral therapy. 58% of the people who got that recovered, compared to interpersonal psychotherapy, 53%. You have some others here, CBT, 44%, behavior activation, 45%. So computerized CBT is effective. Now, to really understand these figures, though, you need to know that in the UK, they do stepped care, which means that people who have milder cases get the less intense treatment. So the people who got computerized CBT had milder cases of depression than the people who got CBT or behavioral activation. So you have to take this with a grain of salt, right? This is not a randomized controlled trial, okay? But the fact that 58% of people with mild clinical depression got better, we got to pay attention to that, right? I mean, if we can help 58% of people with mild depression, then we, live therapists, could take care of the ones that have more moderate and severe depression, right? But again, notice the percentages here, 44 to 54%, somewhere around 50%. Out in the real world, CBT does not seem to be as effective as in randomized controlled trials. And the reason may be because of drift, right? Therapists don't do CBT the way they're taught to do CBT, right? We start doing it our own way, our personal style. And so it drops down in efficacy a little bit. Online stuff does not, because the website or the app always provides therapy exactly the way it was tested. Okay, now let me go on to the idea of a skeuomorph. Skeuomorph is a derivative object that retains ornamental design cues from structures that were necessary in the original. They are deliberately employed to make the new look comfortably old and familiar, or are simply habits too deeply ingrained to wash away. And if you understand what a skeuomorph is after hearing that, you're much smarter than I am. This is a very difficult definition. So we need simpler explanations. So here, let me give you an illustration. This is a candelabra with real candles. This is an electric candelabra where the light bulbs are in the form of a candle, right? This is a skeuomorph. It's not a real candelabra, but it looks like a candelabra, right? Same thing with this. I mean, we all have these icons to save our files. We don't use floppy disks anymore. And if you have a smartphone, you can hear the shutter when you take a picture. There's no shutter. It's just to kind of make you feel comfortable with the way it used to be. Let's not do that with therapy. Here's individual therapy and group therapy. This is a skeuomorph of individual therapy, teletherapy, very helpful. Everybody's doing teletherapy now with COVID, right? It's very helpful. Patients love it. They're more likely to attend therapy. Dropout rates have gone down because they don't have to travel to the clinic. Teletherapy is a good thing, but it's a skeuomorph. It's just doing the same kind of thing, in this case, using Zoom. Let's say you can do Zoom groups, right? Group therapy. This is a skeuomorph, and it limits what we can do with online CBT. I mean, we know, for example, that the modal number of sessions in mental health centers is 1, the modal number of visits to internet interventions is 1. People come once and they never come back. So we need to be, it's limiting online CBT to provide traditional therapy sessions because it doesn't use the potential of digital technology. So how can we help people in one session? Could we do micro interventions? One session RCTs, nano interventions, just self-monitoring, text messaging. These digital apothecaries could have very brief interventions. We could provide personalized behavioral prescriptions, and the user would own his or her data, so they can share it with their physicians and so on. We could do unobtrusive monitoring. The smartphones can now hear your voice and tell whether you're feeling depressed. What if Siri, could say to you, is this a good time to talk? You're sounding kind of depressed. Would you like some suggestions on how to feel better? I mean, these are things that we could do beyond this geomorphic form of doing CBT. We could also measure impact in ways that are unobtrusive. For example, there was a radio intervention in Tanzania, which has a big mountain range. One side, the radio intervention occurred, the other one didn't get it. And to evaluate the AIDS prevention study, they just looked at condom sales, right? Rather than asking people whether they were using condoms. And in Mexico, something similar, contraceptives. They looked at sales of contraceptives. So you don't have to ask people this. So how many people could we reach with digital interventions? When I began this work in 1997, only about 70 million, less than 2%. In 2010, we were up to 2 billion. The last figure I found in June 2020, almost 5 billion people, almost 2/3 of the world's population, which is why we at Palo Alto University have developed this Institute for International Internet Interventions for Health. We have developed this first digital apothecary in which we're offering cognitive behavioral, depression management courses. This one is the Mothers and Babies course in Spanish. We're doing a mood screener that's done in English, in Spanish, in Russian, in Arabic, in Chinese. We are running this project now, COVID-19, What to Think and Do, in which we're basically crowdsourcing thoughts and activities that people all over the world have found helpful in remaining emotionally healthy. It's in Spanish and English. The basic idea, and that's how I'm going to finish here, is we need to think globally and act locally, right? We know depression, smoking, other things are global problems. We need to act locally and treat them and prevent them in our communities. But once we learn how to do that, we need to share globally. And the reason that I'm so focused on this is because, as Carmen said, I grew up in Peru. I grew up in a small town called Chosica, 40 kilometers east of Lima. This is a Google Earth picture of Chosica. The western part of Peru is a desert. As you can see, the mountains there are all barren, no life. The only source of life is the river. It's called the Rio Rimac. Rimac is the name of the river. When I was 10 years old, my mother sat me down and said, your father finished primary school, I finished high school. We want our children to go to university, but we don't have the money to send you. So your father has decided to immigrate to the US, where there are many educational opportunities. And when you finish your education, share what you've learned with people here. And she told me two things that night. One of them is that education is worth a lot. It's worth traveling halfway around the world to get. And when you get it, you should share it. And this is symbolic to me of what we could do with internet interventions. The internet is like a river of information and of interventions, right? That can can provide life-giving interventions to people in the thousands of small towns like Chosica, where I grew up. We should be doing that. We should be doing that. And the message I'm leaving you with is that massive open online interventions and digital apothecaries filled with CBT interventions can contribute to making healthcare a universal human right. Thank you.
Thank you, Ricardo, for sharing so much knowledge with us, and congratulations for this brilliant and refreshing presentation. Really good to hear you again. A great pleasure, actually. So we have some questions we would like to hear you about, and to don't lose the opportunity to hear you about. One of them is based on this growth in online intervention associated with the increase of adherence due to the pandemics. How do you see the future of online interventions? what can we expect? Because actually you talked a little bit about it, that we could do more, not just put the individual or group interventions through technology. What do you think will stay, and what do you think will change definitely? So we would like you to do a little bit futurology.
Well, the first thing is, I think that what COVID has done is it has accelerated social change dramatically, right? I mean, the number of people who used to do teletherapy in the beginning of 2020 was very small. In fact, I think most therapists would look down on people who did teletherapy. They said, you know, you're not really doing real therapy, right? Well, now I think 90%, 95% of therapists have to do teletherapy because we can't get together with our patients, right? So I think we've learned that, in fact, teletherapy does work. And there had been research studies before then showing that it did, but we still didn't believe them. But now we have been forced to do it. And now that we know how to do it, we're not going to go back entirely. I mean, there will still be live therapy, and people prefer live therapy to online therapy. Often there are many patients who much rather see their therapist in the same room. But there are many clients, patients who prefer teletherapy. You know, I think at San Francisco General Hospital, for example, at San Francisco General Hospital, which is a hospital that serves very poor people, the no-show rate, the rate of people who do not come to therapy, has dropped tremendously. That is, more people are coming to therapy more often than doing teletherapy than they did when they had to come to the hospital. And that's because many of our patients have so little money that they can't afford even to pay for the bus fare, you know, to pay for the, or they have children that they have to take care of and they don't have money to pay a babysitter, so they can do it better in their own home. So there are advantages to teletherapy, and we need to take advantage of those advantages. And so I think teletherapy is here to stay. There will still be people and therapists who would prefer to do things online, live. And we should definitely keep on doing that. We should make that available. There are some things that cannot be done via teletherapy. I mean, there are some kinds of interventions need for you to be in the room. But the proportion of teletherapy that will happen is going to grow tremendously, and it's not going to go back to 5% or whatever it was before. The other thing to think about is that, you know, we need to move beyond websites to apps, right? I mean, everybody has, not everybody, but a large proportion of the world now has smartphones. And so apps are the way to do digital interventions. I consider apps part of online CBT, right? You download it and then you have it on your smartphone. So we need to move more to smartphones and move beyond just websites. We need to use text messaging. Aline Barrera, who is doing the online mothers and babies course, is using it, what she calls baby text, which is an intervention that uses text messages, because people are more likely to respond to text messages than to go online and to a website, right? So these are the kinds of things that I think we need to move toward.
Perfect. One question more. Do you see any difference in the focus of online prevention programs caused by the COVID-19 pandemics? What I mean is, did the pandemic bring another kind of concern for prevention programs, or how do you think that the prevention programs are being impacted by the pandemic?
That's a good question. I think I'd like to begin by mentioning differences between prevention and treatment programs. One of the things that we need to take into account is that many of our populations do not want treatment. They are afraid of the stigma of going to see a psychologist or psychiatrist, right? That's why we call our preventive intervention the Mothers and Babies course. It is a course. The women who come to that are not patients. They are not psychiatric patients. They are not mental health patients. They are participants in a course. They are students in a course. And I think that's a major difference, because in San Francisco, a lot of Latinos do not want to see psychologists. Eso es para locos, and that's for crazy people, right? And so, but by doing preventive interventions that are not therapy, they're not treatment, we can get more people in to benefit from cognitive behavioral interventions. So that's an important difference. The second one, referring to COVID, is that I think many people are realizing that the fact that we're all confined now in our homes, you cannot get together with our family, can't hug, our mothers or grandmothers or something, is causing a lot of psychological and emotional pain. And I think the idea that a stressful event like COVID, which is affecting the entire world now, is bringing attention to the fact that stressful events can produce emotional problems. I mean, everybody knows that now. You can't get away from that. So I think it'll at least make it more real what the effect of stress has on human beings, and that we need to do something to prevent depression, anxiety, PTSD on these large populations. We need to be thinking population level. We need to be thinking at prevalence in the community, not just does this person have depression and can we treat the depression? But does my community have risk for depression, anxiety, PTSD, alcohol problems, domestic violence, child abuse? I mean, all these things are increasing because people are stuck in their homes, and we need to prevent those. So I'm hoping that'll help us focus on prevention more.
Perfect. Well, we could stay here listening and learning from Dr. Muñoz for a long time, but unfortunately we have to close. So, Ricardo, I have no words to thank you for your availability, your generosity with all this information and answering our invitation. And in addition to always impactful contribute for provide more information and research data for us to do better our work. Thank you so much.
Thank you very much. I feel very honored and grateful to you for having invited me. Thank you.
Okay, and you stay with us. We still have a great schedule ahead. Now let's continue with our symposium schedule.